Okay, it is 11:05. I think we will get started. I'm Janine Graves. I'm the chair for this meeting, and we're going to go ahead and call roll. So please answer kindly. We have Dr. Sajay De Guzman.
Present.
Thank you, Sajay. Dr. Tanya Altman.
Present.
Thank you. Dr. Tammy Van Tol.
I'm here. Can you hear me?
Yes, sure can.
Okay.
Thank you. And Sherry Fortin. Sherry, I think you're muted.
Hello, Cherie Fortin here.
Excuse me. Thank you, Cherie. And if I butcher a name, please let me know. Wendy Hasbro.
Good morning, everyone. I'm here.
Thank you. Dr. Chan.
Good morning. I'm here.
Alice Benjamin.
Present.
Thank you, Alice. Judy Cornell.
Hi, I'm here.
Hi, Judy. Kathy Hughes.
Here.
Thank you. Jacqueline Bauman.
I'm here, Jacqueline Bowman.
Bowman, thank you. Ariel Hernandez.
Present. Thank you.
Thank you. Dr. Spetz.
I'm here.
All right, wonderful. Wonderful. And I don't see in the participant list Hazel Torres, Chris Perry, and Sandra Miller. And I think they let Macaulay know they would not be here today. Is that correct? So we have plenty of people for a quorum, so we will go ahead and consider that established. Next on the agenda, item 2.0 are some general instructions for the format of this teleconference meeting. Mark?
Good morning. This is the BRN moderator. I will be moderating the meeting. To facilitate public comment, we will be utilizing the WebEx question and answer feature, now known as Slido. When the committee reaches a point in the agenda at which public comment is appropriate, the question and answer feature will be turned on and members of the public can indicate that they would like to make a comment by inserting the phrase, "I would like to make a comment," in the question box, which is typically in the lower right of your screen. I will then call on the individual and unmute their microphone. The individual will have 2 minutes to make their comments. I will not give a warning as your time approaches. I will mute your microphone and will announce that your time has exceeded the time allotted. I will then proceed to the next member of the public who has a comment. We will also query our in-person location in BRNHQ. Please note that the question and answer feature is being used only as a means for members of the public to represent that they would like to make a verbal comment. When your turn comes, you will be prompted to unmute. If your question can be answered, the committee will respond accordingly. When making your comment, speak about anything you believe is important for the members to know. Remember, committee members cannot address any item not on the agenda. Items not on the agenda at that moment, items that you would like to add to a future meeting, or items that will be discussed later on in the agenda will be discussed at their correct times during the meeting. I will provide a brief reminder of this approach at the start of each public comment item. Finally, when the committee members or BRN staff are not speaking, I would like to remind them to mute their microphone. If I detect background noise during the meeting as a result of unmuted microphones, I will mute your microphone automatically.
All right. Thank you, Mr. Moderator. Item 3.0, public comment for items not on the agenda and items for future agendas. I'll open that up to the group.
Janine, this is Garrett. I think it's open to the public. So do you want to open it up to the public?
Yes, please.
Okay, thanks.
Open to the public.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for a comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you'll have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Preston Santi would like to make a comment. 1 second, please.
Hello. Can you guys hear me?
Yes, go ahead.
Yes.
Fantastic. So my name is Preston Sante. I'm a nursing student at Samuel Merritt University, and I'm wanting to, I guess, request for future, the word escapes me. I'm sorry. For this to be addressed with NUAC. Basically, that I want to alert the committee that the workforce data that you're receiving for the Oakland region is invalid. While my university reports a 95% success rate, this excludes the actual reality on the ground. And in consideration, an example, in December 2025, that graduation cohort and for the BSN, 44 students failed their exit HESCU. They were blocked from graduating and were placed in progress status. Basically, they were labeled in progress rather than attrition. They are statistically invisible to you guys. So you're receiving data that shows a robust pipeline when in reality the pipeline is clogged by administrative gatekeeping. I'm asking that NUAC requires schools to report accurate in-progress rates, not just graduation rates, so that the state can see true bottleneck in the nursing supply.
Appreciate your feedback. This is Loretta Melby, or Lori. I'm the board's executive officer. Just for a quick to use, just kind of educational purposes, you do have an assigned nursing education consultant that is specific for Samuel Merritt. They are, I'm assuming they're on this meeting as well and listening to this. You may consider reaching out via our website at rn.ca.gov. There's a contact us form. And if you fill that out and put nursing education or scope of practice issues, it will go directly to the nursing education consultant group. They are the group within the Board of Registered Nursing that are responsible for the oversight and collection of that data, and could assist you in looking into that further. On a quick side note, we do only monitor annual NCLEX pass rates for first-time test takers. So there are times where it will be a low report for one quarter and then a higher report for the next quarter. And because we look at all 4 quarters, it does average out. We do look at attrition and on-time completion as well. So we will get to that information eventually. We appreciate you bringing that information forward to us. And I do really encourage you to reach out directly to the Contact Us page so you can get in touch with your nursing education consultants that is assigned to that school, and they can look at that further. We also do have an ability on our website to submit a complaint. And so you could submit a complaint around that information regarding the school, and that can be looked into as well.
Okay, thank you.
Thank you.
Thank you for your comment. Oh, I did have someone. Hold on here. I thought.
Yeah, Lisette Ruiz.
Lisette. Yes, I thought she had a comment. Let's see if she still does. Hold on.
Hi, good morning. I did have a comment. However, I'm sorry if I mispronounced. Loretta already confirmed. I'm also a student from Samuel Merritt University about addressing some concerns. Excuse me, some concerns we had and discrepancies to based on the website to email someone on there. So I guess I will just withdraw. Thank you.
Thank you for your comment, and thank you for showing that you can withdraw your question. So that's if I see that again and then it disappears, I won't panic. Um, I don't want to miss anybody. Sorry. um, uh, Committee Chair Graves, there are no public requests for comments, no more public requests for comments on the WebEx, and I'm informed that we have no public representation in BRNHQ. Would you like me to close this window?
Yes, please. Thank you.
Thank you.
Moving on to item 4.0, review and vote on whether to approve the previous minutes, meeting minutes. So we did meet on September 10th and entertain any kind of comments. And if someone would like to vote to approve acceptance, or if there's any changes that need to be made on the minutes.
I have no edits and I move to approve.
I'll second that motion.
So do we need a roll call vote?
Yes, you
This
do.
is Reza. Yes.
right.
For the record, that was, I think, Tanya who did this. If you could mention your name when you're doing motions and seconds, that'll help our note takers. Thanks.
It was Tanya.
Okay. Fantastic. So we will take a vote. Sajid de Guzman,
Yes.
Tanya Altman,
Yes.
Tammy Van Holt,
Here.
Cherie Fortin,
Tammy, was that a yes vote on the motion to approve? I'm sorry, not Tammy. On the motion to approve the minutes?
Yes.
Got it.
and I think Dr. Altman seconded. Is that correct? Keeping it straight.
Correct.
All right. Wendy Hasbro,
Yes.
Garrett Chan,
Yes.
Alice Benjamin,
Yes.
Judy Cornell.
Approve, yes.
Thank you. Kathy Hughes. Kathy? We'll come back
Sorry,
to
I keep
Kathy.
muting and unmuting. Yes.
I know. It's only hard to find it when it's time to say something, right? Thanks, Kathy. Jacqueline Bauman?
Good morning. I wasn't at the last meeting,
Oh,
so
you can
I don't
abstain.
think I can. Oh, I'll abstain. Thank you.
Sounds good. Ariel Hernandez?
I will also abstain since I wasn't at the last meeting.
All
Thank
right. And Dr. Spetz?
Yes.
All right. Looks like that.
I think I was skipped. I'm sorry to
who's that?
interrupt, but this is Cherie Fortin from California Community Colleges.
Oh, I did mention you, but thank you for your vote, Cherie.
And then real quick, Janine, we do need to go out to public comment for the meeting minutes. We did the motion. We're doing the roll call. I don't believe we went to public comment.
All right, let's do that then.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Sorry. Wow.
Are you
Please
okay,
remember
Mark?
you will have, yeah. Yes. Please remember you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Sorry about that. Committee Chair Graves, there are no public requests for comments on the WebEx. We have no in-person representation in BRN HQ. Would you like me to close this window?
Yes, please. Thank you. So moving on to items starting with 5.0. Before we start into this, sometimes our discussions can be rather lengthy in this committee meeting. So we will be taking a short 5 or 10 minute break in the middle just to for VTE prophylaxis and just to allow people a moment to stretch. So don't worry, we'll have that time where we can, get up and stretch and get the circulation going again. Item 5.0.
Janine, sorry to interrupt you. This is Reza. Just a quick comment, if I may. We've got a couple committee members with their cameras off. It's actually a requirement under the Open Meeting Act for us to meet remotely like this to have your cameras on. If you're having like bandwidth issues or some technology issues, do let us know, because then you probably get a pass. But otherwise, if everything's working as it should, we need everyone to be on camera. Thanks.
Thank you for the reminder. Appreciate that. So item 5.0, report from the Board of Registered Nursing's Executive Officer regarding updates on activities which may impact nursing education and our workforce, including legislation, policy and procedure changes, regulatory updates, and etc. EO Melby, you have the floor.
Thank you. I appreciate that. We've had a busy few months at our board, and so I do want to kind of recommend that you guys go to our website and look at a couple of our documents. One of the major documents that I recommend that this committee go and review, as well as stakeholders, is our Sunset Review report. This year is our sunset review process that is going through the legislative process. A bill will be introduced soon, and we will start that process. We anticipate having a hearing scheduled in probably March. That report is something that we are mandated return in early January. We have submitted our report that is also available on our website. It is a lengthy read, but if the public wants to pare that down, some of the really important things that I think would be beneficial for the public and this committee to really take a look at are the executive summary, and then looking at sections 9 and 10. Sections 9 are responses that we wrote regarding previous issues and items that the legislative representatives have addressed. And then section 10 is our kind of personal review of BRN and what we would need in order to kind of improve upon some of our processes. Understanding that BRN's ability to provide the services that we do lies in the statutory abilities that's granted to us through the legislative process. And any of our policies and procedures are truly regulatory updates. And so that needs to go through a legal process to do a regulatory update. And a lot of those times we need statute to support that so we can move forward with those. So it's not as easy as just kind of forming a committee and saying we need to change these policies and just go ahead and do that. So definitely recommend you taking a look at those reports that are on our website. You could just search for Sunset, or you can go from our homepage on the right-hand side where it says reports, and you can access that report there. The other item that I think would be great for this committee to look at is we just adopted in November, our board adopted a brand new strategic plan that will be going out for the next foreseeable future. And so within that strategic plan, you guys are able to look at what our board is highlighting as priority over the next few years, and the various initiatives that we'll be working on to bring those forward. And so that is something that is on our website as well. And what you can do there, an easy one that I always do, is just go to the right-hand corner of our homepage and search strategic plan. you will see that what comes up on search is our last strategic plan that has been closed. Some of those items were carried over and added to our new strategic plan, but you will see the updated strategic plan there as well. So those are two documents that I want to call to your attention that are on our board's website that you guys can look at. And really just kind of understand where our board is kind of focused this coming year. And knowing that Nursing Education Workforce Advisory Committee, as well as the public, all have the ability to kind of communicate up to our board and provide us with information. Those are the biggest changes that I just wanted to highlight, not necessarily changes, but just kind of projects that we're looking forward to that really would appreciate any feedback that you guys might have. And then please participate in the upcoming legislative session. I'll be there working hard, getting that done too. So your feedback is pivotal. Thank you so much. Any questions from the committee? I'm not seeing any questions from the committee. So at this point, we can go out to public comment. We won't need a motion or anything. There is no action that needs to be taken on this. So it is information only today. We can go out to public comment on this. Thank you, Board Moderator.
Just a moment. I did look up, is that the 2026 to 2030 strategic plan?
Yes, it is.
Okay, that's at the top of the list when you type into the search. So that worked great.
Yep.
So now go ahead and send us out for public comment, Mark.
Thank you.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Graves, there are no public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes, please.
Thank you.
Thank you for that information. Moving on to item 6.0, report from the 7 NEWAC committees. The simulation standards, Sandra Miller and Garrett Chan.
I don't think we have anything. We finished the first phase of the work and forwarded it on to the board. And Lori has been diligent about moving that forward. So I don't think, Lori, unless if we have anything else, it's on hold until the board decides what to do next, right?
It's actually not on hold. It's actually part of our section 10 of our sunset report, where we did bring forward some recommendations regarding simulation that we're hoping that the committee will take into consideration and look to see what can be done to address some of those standards.
Thanks, Lori. I'm sorry, I wasn't.
No, that's
super
totally
clear.
okay, Garrett.
Our subcommittee is on hold until the board does whatever the board does. So that's what I meant. So I apologize, but thank you for the clarification and the new information that we have. So I have nothing else.
Great. Thank you for your report. Clinical placement and impaction, Dr. Chan and Judy Cornell.
Yeah, Judy and I are still trying to coordinate calendars for our work. And so I apologize. The latter half of the year was really busy for me. And so I have been the person that's been difficult to connect with. So I look forward to connecting with Judy in the near future.
Yeah.
Judy, do you have anything else you wanted to add?
No. It's at the end of the year was a bit of a challenge, and so that's all right. We'll get it connected and get working on things soon.
Great. Thank you so much for that. Cultural competency, diversity, pathways to nursing, Jacqueline Bowman and Anthony Cordova.
Hi, I don't know if Anthony Cordova is on this committee meeting this morning, but I did miss the last two meetings of the committee. So I do need to connect with Anthony and then have something to report out for the next meeting. So I apologize for that.
And then just to clarify, the new contact would not be Anthony, it would be Cherie, and
Right.
she is on this meeting today. And you guys can work
Wonderful.
together at getting that connected.
All right, fantastic. Thank you.
Thank you. Just for the public, just so they understand what occurred right there, is we didn't just randomly replace a member. That committee person's position is that of representation of the California Community College's Chancellor's Office. So it is not a specific person. It is a position that's filled, and that is Cherie will be serving in that role right now. Thank you.
And I think Macaulay can help you with connections if we don't have each other's contact information. And
Wonderful.
then,
Thank you.
wonderful. Thank you for that. Theory Practice Gap and New Grad Orientation, Kathy Hughes and Wendy Hasbro.
I don't have any updates.
All right.
Yeah, there's no updates at this time. Thank you.
Thank you for that. Workforce Retention, Hazel Torres and Ariel Hernandez.
Nothing to report at this time. I'm also replacing former CNA Representative Carmen Comste and look forward to connecting with Hazel on the subcommittee.
Wonderful. Thank you. Curriculum Standards and Guidelines. Sajay and I, went in a different direction after Lori's report and realized that this is a much bigger process than just our subcommittee work. Sajay, do you have any comments for the group?
No, I don't think we have any more updates. But last meeting, there were recommendations of changing the terms, medical, surgical, nursing, or the psychiatric nursing. But we're gonna look at that. But however, there are no updates for now.
Being in the clinical environment, watching impact,
Right.
the impact of AI is truly significant. And I know that the board is sensitive to that and will look at it.
That too.
It is real and it does impact our care of our patients. And so we are really relying on our faculty to help the pre-licensure nurses understand the guardrails and understand, how to implement that appropriately into their care. So it's something that's new for a lot of people. So that was something that both of us were very interested in.
Right.
Thank
And,
you. And then just to provide some quick information on that, if that's helpful. Our
Yes,
regulatory language is not exclusive, it is inclusive. And so really wanted to make sure that you guys were aware that even if it's not called out specifically in 1426, that you guys can discuss AI or shall discuss AI, that you guys have the ability to do that as part of your curriculum and make that as heavily or not as heavily as you guys need to based on your curriculum and the ability to provide that information. So if that is something that you guys absolutely want to look at as part of your subcommittee and you want to make any recommendations on that, we're happy to bring that up. It does not necessarily mean that there needs to be an update to the regulatory language because again, it's not exclusive, it is inclusive. And so you guys can add anything additional to what we've set as minimum standards. One of the things that you could do is ask us as the board to update that regulation to require AI to be included in that. Again, that would also come with, evidence that would have to be done. It'd have to be in alignment with where California's more global kind of strategic plan sets with the current governor, et cetera. And then wanting to make sure that that's all balanced there too. So, but any kind of input recommendations are always welcomed. Thank you.
So does the strategic plan address any types of curriculum changes, or do we just have a foundational understanding that the curriculum is inclusive and the faculty can address those practice preparations accordingly?
So in our strategic plan, we do talk about educational oversight, and there are some kind of conversations and stuff around that we're also always looking at. But there is this general understanding that we set minimum requirements, which is only at very basic entry level stuff, that anything that our program wants to do to launch from there, specifically in alignment with their accreditors, anything like that, they absolutely can. The reason that we don't typically update curricular requirements in our regulatory standards is that those are licensing requirements, right? And so what we don't want to do is something that our California schools are doing here. We don't want to make that a licensing mandate, because then if it does, by updating our curriculum standards, it makes it a licensing mandate for every state in our nation, every territory, as well as internationally. And so that's why we look at minimum standards that we set for licensure, which is our curriculum, which is very basic. And we allow our program directors to launch from there and do what they need to do to manage their population and what they need to do to in alignment with their objectives and graduate goals, et cetera.
Yeah, might be a nice topic for the National Council State Boards of Nursing as well.
They're already on it. Just letting you guys know.
Is that right?
There, yeah. Phil Dickinson is their CEO, and he was the big one on Next Gen NCLEX, and really a proponent to utilizing AI and seeing what can be done. So they are kind of the leaders in the world, honestly, with AI and nursing education. So I firm belief that NCSBN will be taking a look at that, looking at any kind of regulatory things for the boards of the United States, as well as our 4 territories, and providing any kind of guidance that we might need.
Fantastic. Thank you for that. And the last subcommittee is faculty with Dr. Tanya Altman and Tammy Vantvol.
Hi, thank you. With the help of the BRN and Macaulay, we did a survey of deans and directors. We didn't get a really high response rate. And quite frankly, I think what we found was what we already know. Our survey was in 2 parts. We looked at faculty in general, and then we also looked at directors and deans and directors, knowing that there is some succession planning issues coming on. Barriers to face for hiring full-time faculty, the number 1 and number 2 were tied for low salaries and need to maintain an outside employment. So I think that's pretty telling. We looked at why they need to maintain outside employment. It was about 50-50 between just making a living and the other one of being current and up to date and approved to be the director. The next barrier was a low applicant pool with advanced degrees. So those were things I don't know how much this committee can work on. Barriers to retaining faculty. It kind of seemed that if faculty made it the 2-year mark, the barriers to retain them kind of went away. But the top 2 barriers were, again, salary at 96% of the respondents saying salary was bad. 62% said adequate preparation to teach was another barrier and a reason people left before the 2 years was up. Of the respondents in the director's role, they were mostly over 55 years of age. All of them were teaching workload. 81% said they had a teaching workload overload. And so they were doing beyond more than 50 plus hours a week in their role. And 40.5% of them said they plan to leave the director's role within 1 to 5 years. So I think one of the issues we really need to start looking at is succession planning for the next directors.
Well, I know that just in nursing in general, when you're having a 45% flight risk of your staff, the first thing you look at is retention instead of recruitment. So I'm just curious, how are you going to retain these wonderful faculty at our schools?
That's part of the problem. I mean, I looked at a little bit on mentoring and how many mentoring places, and they are starting to get mentoring within the colleges and stuff. But again, part of that is the budget to do campus mentoring. of these faculty and to train them and stuff. I know personally, I've been trying to get some sort of way to incentivize my faculty to take the Benner Institute teaching and learning thing. And I'm getting nowhere on campus. So I those are some of the issues we've got to
I
address.
was just going to chime in. Thank you, Tanya. I was just going to chime in too that, you know, for the community colleges, the R&I funds through the Community College Chancellor's Office is focusing on faculty retention and recruitment. So, you know, if you had something innovative, you could, you know, propose. So, I mean, I do think that it's being recognized that it's a problem. So, I mean, there's a little help there.
So it sounds like the same situation about the city colleges and the universities.
Well, I think one of the things, Tanya and I, this is Wendy, we're both from the Cal State system, and the Cal State system has been budget shy now for a couple of years. And so there is no money available for any professional development for our faculty. And so that makes it difficult. I don't know, Tanya, what it's like for you, but for me, there's the professional, unless you're tenure track, and the tenure track are a very tiny part of my faculty. So the majority of my faculty, and until we take seriously paying teachers in this, you know, in this country, really teachers continue to be one of the lowest paid professions, and we are teachers. And so we're paid at the university rates. So most of my, I have a portion of my faculty who are full-time, but the majority of my lecturer faculty are part-time, and they maintain a clinical practice. Just some of them they'd like to teach more, but financially are not able to do that because they get paid so much more in the clinical sites.
I apologize. My computer bandwidth timed out or something. I don't know, but everybody froze for a moment, right? As I heard something about the California Community Colleges R&I grant. So I'm hoping we could circle back to that if there was a direct question for our system.
No,
Yeah,
I was just
going to add. Go ahead, Tammy.
I didn't have a question. I pointed out that, you know, it's very helpful that the R&I grant was focusing on, you know, innovative things that we could do to recruit and retain our faculty.
I will add, though, that grant is specific for community colleges.
This is Alice Benjamin. Can I ask a quick question? And pardon that I feel like I should know this answer, but I don't. So full transparency, what is it that the physicians do to maintain their, you know, their professors? Do they have a best practice? Do they have a model that we as nursing can attempt to try? Or are they having the same issues that we're having?
They're having the same issues that we're having. There is definitely a lack of providers, a lack of entry into the profession, and minimum amounts of like residency programs, et cetera, like that. They just don't have the support as well. And that's why they have those, you know, where they hope to get the position that they want to get so that they can work in that. And that's why our APRNs really come in handy to help serve and work towards addressing the provider gap. So it is a systemic issue. It is not limited to profession.
Alice, I would also add, I totally agree with what Lori had said. I also want to just be clear that graduate medical education is really funded mostly at the federal level. The Centers for Medicaid Medicare Services in 2022 paid out $22 billion with a B dollars to academic medical centers to help kind of support the education of physician trainees, whether it's residents or fellows. We don't have that level of funding either at the state or at the federal level. And so it really is, and then with the reduction at the federal level of even loans and scholarships through I think it was Title VIII funding, there was a reduction, I think, of $400 million or so for nursing, advanced practice nursing education, and also the challenges we see in the budget as it relates to Health Resources and Services Administration, HRSA grants. We are really struggling in general in nursing education.
You bring up an excellent point, Garrett, that needs to be highlighted, and that is that healthcare organizations are monetarily committed to medical training, and they are not committed to nursing training. And I know for myself, I hope some of you will echo this, that probably the biggest stress I have in my job as director is battling every semester for sufficient clinical sites. And that continues to be a problem. After COVID, we came out of COVID, and the numbers of students that will be approved now for clinical sites has dropped, and it has stayed down post-COVID. And I scramble almost every semester to find enough clinical sites for my students' clinical experiences. It's a problem.
Yeah. And Wendy, I'm going to talk about that a little bit in the next agenda item. I think it's the next agenda item.
It is the next agenda item. Yes.
Thanks, Lori. Because I think that you, again, bring up a really important point. And so anyway, I just wanted to put that out there, Alice, because while medicine does struggle, as Lori said, they also have financial resources that are not available to nursing. And so we have to figure that piece out, even though we're the largest health professions group in the United States. We're not getting the levels of support that other, like physicians do. And physicians are their own unique group, right?
Right.
Respiratory therapy, physical therapy, that we are all in the same boat. It's just medicine has public interest funds that are allocated for the education of the future medical or physician workforce.
I think that one of the things nursing has to begin to look at is not just that we are a caring science, but also that there is an ROI to organizations to support us. And from that perspective, it's not just the constant message that, oh, we're going to be in a nursing shortage, but Medicare, federal funding, there are certain things RNs can do that are in their scope of practice that actual organizations could bill for. They typically choose not to. But I think one of the reasons that we see physicians gain more financial support from the federal government is that there is a monetary, if you will, number that can be associated with the work that they do. And nursing has traditionally not wanted to be involved in a business model or not wanted to be involved in understanding the business aspect of healthcare. And I think that has been a detriment to the profession. And so that's something that we may want to consider in the future, is adding a little bit of business acumen and really encouraging organizations to incorporate nurses into their business model so that we can bring more legitimacy, if you will. Yes, we're the most trusted profession. Yes, we are the most caring of all the healthcare professions, I would venture to say. But the flip side of that is that we've hurt ourselves by not bringing on any type of business component to a world that is filled with legitimize yourself by how much you can bring in or what you bring to the table. Nurses aren't able to articulate and codify that as well as some of the other healthcare professions do.
So I'm going to jump in really quick. It's a great conversation. I love it. I would love to participate in this longer. A couple things that I do need to jump in as the board's executive officer is one, just kind of a Bagley-Keene requirement. This is agenda item 6.0. These are just report outs of the subcommittees. So to have these more robust conversations, we will need to agendaize them for a future meeting. And that's because this is discussion and possible action. You guys can absolutely do that right here as part of this committee. You can say, I want to add to the next agenda a discussion on such and such, and that could be the motion that comes out of this discussion. So I don't want to shut you guys down. I want to make sure that we're following our legal guidance, that we do have to agendaize this greater discussion. Great discussion. I would love for it to continue. The next thing I just want to kind of clarify is that when we were reporting out on faculty, there was some conversation around faculty wages. And I want to really make sure that our board is pulled out of that discussion. We cannot be part of that discussion. We are a licensing board and an enforcement board, and we do not have any influence over any kind of pay scaling or anything to that effect that is handled outside of us. And that includes conversations around billing. So we are not involved in any conversation on billing and the ability to bill, et cetera. So we have to be pulled out of that as well. So all those are wonderful discussion pieces and big pieces of information that does need to be shouted at the rooftops there for everybody to hear. I'd be one of them out there with you guys. Cannot do that under the official functioning of the Board of Registered Nursing. We do have to show that we are completely separate from that, so that it doesn't look like we're trying to like corner the market or do anything inappropriate because of our ability to license and remove license. We could then be seen to affect supply and demand, which could then affect wages and stuff like that. And we need to make sure that we're completely separate from that. So just to jump in and provide a gentle redirect, but do allow for continued conversation if you guys do want to put forth a future agenda item to have any additional conversation of something that is within the jurisdiction of our board. We'd be happy to add that to an upcoming agenda. And then on the clinical stuff, hold that. I guarantee you the next agenda item is going to be definitely a place where we can kind of talk about clinical impaction and stuff, because that is the bill that was just signed into law that we're looking at implementing. So anything more on 6.0 from the committees that you guys would like to share? It is discussion and possible action, so you guys could do that, or you can serve this as information only and we can go out for that. So just let me know how you guys want to move on with this topic.
May I make a quick ask of the faculty committee? And I think the best way to do this will probably be through Macaulay to follow Bagley-Keene. I would love to see the questions that you asked in your survey of deans and directors. They also, get questions about their faculty recruitment and their own positions in the annual school survey that is now in final analysis for a draft report that will be delivered to Stephen Wong, who then spreads it around the board for commentary. But there may be questions that you asked that would be useful for us to incorporate into a future iteration of that survey. And that also, depending on what timing you were in the field, it might have affected your response rate. If you were in the field at the same time that we were asking deans and directors to complete the survey that is required for the board. So that, the information you gathered sounded great. I'm going to guess that for Bagley-Keene that information probably needs to go through Macaulay and to get conveyed to me. I could be wrong about that, but I would love to see it so we can think about what might be added to future school surveys to enrich them and answer the kinds of questions that your committee is interested in. Very quickly, also on economic competencies, that is an area where a professor in Michigan invited me to participate in a couple of journal articles she wrote about economics and health finance competencies for registered nurses, including a survey of chief nursing officers about what they wished their staff knew. So I will ask Macaulay to share that out with the appropriate people.
So just again, to jump in and provide some guidance again, Tanya, your survey questions, if we do want to share it out, we should go ahead because you guys are already two as a subcommittee, and then adding in additional person is a member of this committee. We would want to agendaize that and have a more robust discussion on your survey and what went out and what your results were. I know that was one of the questions that was sent out by Macaulay to your guys' subcommittee when we were doing the agenda, is whether or not it was just going to be a brief report out of where you're at in the process and that you're analyzing data, and not necessarily a report out of the survey itself and what the results were. So in order to capture that appropriately, we would have to go ahead and have that as an agenda item so that you can discuss that survey in depth and detail and what your findings and what the analysis of that is. And so again, this was just an agenda item that was just for just a blanket kind of in process update, that if we have substantial things to discuss around any of these report outs, we do need to have a separate agenda item. And I know, again, that Macaulay reached out and you had said that you didn't feel that we needed a separate agenda item at this point. That will be coming. When we agendaize that, that information will be able to be shared with you, Joanne. I know that as part of your contract, I'll work with Reza to see what can be released and what can't be released, just as to not violate Bagley-Keene, so you can have that information when you're analyzing the data and moving forward. So we'll touch bases offline on that, on what our legal requirements are and what you can or cannot have based on that. But I do hear your ask and want to address that as it may be impactful. And then again, just asking at this point if there is a motion that you guys want to add something on for a future agenda. And if not, this is information only. And then Joanne, as sharing information out, if you have something that you would like us to link maybe to our website, that might be something that we could do that can get that out to the greater kind of community of stakeholders and not just shared within this group. Again, anytime we share something just within this group, it does need to be shared out as an official part of our Bagley-Keene. So appreciate that. Thank you.
So
Lori?
thank you for that redirect, Garrett.
Oh, I'm sorry. Lori, before, I don't know if this is correct, so please correct me. I wonder if I go through my agenda item next, and then we can figure out what we want to put on the next agenda after they hear what I have to say, or do you want us to do something now for this agenda item to put on a future agenda item?
There is no requirement to do anything for this agenda item. You guys can treat it as information only, and we can go out to public comment and be done. The adding of items to a future agenda does not have to occur in this public setting. I was just providing the ability to do so if you guys chose to. We do a call out before every single meeting and query the entire group to see if anybody has any agenda items that they would like to be added to the committee meeting, and we typically do not receive a response back. So if there is agenda items that you guys want, please, 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 when Macaulay does a reach out, add that and be responsive to that so that we can get agenda items on here that really do facilitate discussion that you guys think would be very important. So not limited, Garrett, to this agenda item, not even limited to your next agenda item. It could definitely be added at any point, and then we will take that back, do an executive level review with legal to ensure that it is within the BRN's jurisdiction, and then we'll move forward with that.
I think having the conversation of the next agenda item might give a full picture of what people might want to put on a future agenda. So that was my recommendation. So
Thank you for that. Before we go out to public comment, I will ask if there's any member of this committee that would like to add input to these committee report outs. Hearing none, Mr. Moderator, would you please open the session for public comment on this information only item?
Board moderator, if you're speaking, we cannot hear you.
Oh, that was weird. It wouldn't let me unmute. Sorry. Um, we will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for a comment. Whoa, my machine is acting weird.
I'm glad that happens to you too.
Yes, this is interesting. What's going on here? It's almost like something is open. I cannot open up Slido. Sorry, what is going on?
Board moderator, we are an hour into this meeting. It might be a good time for us to take that break that you were talking about, Janine, so we can address any technical issues that our board moderator might be having so that we can ensure that we do have public comment moving forward.
I'm sorry.
You got it?
Okay, I got it. I got it.
Awesome. Okay. Public comments important. We can't go on without it.
Feature. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you'll have 2 minutes to make your comment. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." I had a window in the background, just FYI. So I've seen what you guys see. Or didn't see what you guys saw.
So as far as you can tell, people can like, oh, there's Judy.
Oops, oops, oops. And Judy Corliss would like to make a comment. 1 second, please.
Hello, can you hear me?
Yes, ma'am.
Yes.
Go ahead.
Hi, this is Judy Corliss, and I am a former board member and actually served with Janine Graves. And I love the work that you guys are doing. And I have a question. Has anybody reported out how the clinical site distribution is going since the board went through the process to reduce the required clinical hours outside of the colleges of nursing? To go to clinical sites, they reduce it to 500 hours. Many of the schools that I talked to recently when I was at COADN and various meetings, a lot of them have not reduced any of those hours. And I realize they need to use simulation and maybe they don't have it. But if that ever gets leveled down a bit, it should make a difference. Do we have any statistics on that? Because I haven't seen any, and maybe you have them and I just didn't know where to look. Because I think in the end, it will make a difference.
Yeah, so we believe that it will make a difference. We haven't been collecting statistics on it yet, but what we did see during COVID was a sharp realignment to our minimum requirements of 18 units of clinical. So our 18 units of clinical still stands. That is a licensing requirement that was not modified with the 500 hours that are required to be in direct patient care. So with that, our curriculum requirement maintains that the minimum for licensure is 18 units, 18 semester units. And so when you calculate that out, it's about 864 hours, I believe, off the top of my head. And so that is still required that the school offer at minimum that for any degree option. Now, previously we had in our regulatory requirements that 25% of each one of those 5 content areas 75% of each one of those content areas had to be in direct patient care. What that did previously is if somebody had a course, say they offered pediatrics as a 4-unit course, they did 75% of that 4-unit course had to have been in pediatrics, which was different than if a program offered a 2-unit pediatric course. It still only required 75% of that to be in direct patient care. Much different numbers when you go from a 2-unit course or a 4-unit course. And because we do not have a standardized curriculum in the state of California, that was different experiential kind of training and access and stuff. So when we brought that forward in COVID, many people that were offering 24 semester units brought their units down to 18 units. So we did have an initial shift in that alignment through starting in 2020. We were getting a lot of curriculum changes. We brought them forward to our board, and they came forward either as temporary or permanent to allow people to progress and graduate. Then when we went through the legislative process in our last sunset, that's definitely when a lot of things happened. We had a 26-page sunset bill, I believe, last time. And so in that last sunset is when we decreased our requirement for in direct patient care to 500. That was in direct response to a lot of the organizations really asking for a one-to-one clinical preparation with simulation. We're not at a one-to-one in California, but we're pretty dang close, which is where better than we've ever been. So if you have 500 of the 864, we're getting there. But what it did was set minimum requirements for each one of the specialty areas, essentially. So you at least had to do 30 hours. What we ran into with that is there were some people, some programs, and I'm saying people, and that's incorrect. I'll correct that. It's some programs that even meeting 30 hours was problematic. We had some people that were doing geriatric hours prior with only meeting 27 hours or only meeting 25 hours of direct patient care. So they actually had to increase hours in those specialty areas to meet the 30-hour minimum requirement. So it is not, you're not going to see an across the board shift where everything went down, right? You will see you will see shifts where some had to bring up hours to meet that requirement or bring down hours to meet that requirement. And so I don't think the overarching thought that everybody came down is an accurate thought, because we did definitely receive complaints from program directors saying that they had to increase their geriatric hours, they had to increase their psychiatric hours in order to meet our 30-hour minimum patient care requirement. So specialty areas are difficult to get clinicals, even more difficult after COVID. So again, we can go into that again in our next agenda item if we wanted to discuss more specifically with that. But even though California is now aligning a bit better, we are setting minimum requirements. And this is the same conversation I had to the students that had shown up in public comment is board approved nursing programs can set their curriculum above what we require minimally. So we say 500, you might have a program that says they want all 864 hours to be done in direct patient care, and they can do that. Right. They do not have to have it. We do not have a simulation requirement. And so they can do all of their clinical work, that 18 units or more if they choose to. They can totally do a curriculum that has 24 units in any direct patient care experiences they want, as long as it meets the clinical objectives. That is our only requirement. And so they set the objectives, they set their curriculum, we review, we approve to make sure it meets our licensing requirements, but we do not ever require board approved programs to decrease to meet something that we have, because our requirements are minimum, not maximum.
Okay, thank you. And I didn't expect everybody would reduce it, but I thought there was some reduction just because of the lack of availability of facilities, which is where many of the schools are having their trouble. So that was my point. Thank you so much, Lori.
Thank you, Judy.
Thank you for your comment. Committee Chair Graves, there are no other public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window? Uh-oh. Judy, you're
on mute.
mute.
Yes, thank you. Please close. We can either take our 10-minute break now or we can power through. What would you like to do, committee members?
Let's do a break.
Let's do a break. All right. So we will return at 12:20, and hopefully, Mark, this will give you a chance to test out your system, and we will reconvene at that time.
Thank you.
Thank you. So it's 10:22. We'll go ahead and take a roll call to see if we do have at least 9 members so we can move forward. So Dr. Sajay De Guzman.
Present.
And Dr. Tanya Alderman.
Present.
Thank you. Dr. Tammy Van Hol.
Here.
Great. Cherie Fortin.
Present.
Wendy Hasbro.
Present.
And Garrett Chan.
Present.
Hazel Torres. No. Alice Benjamin.
Present.
Judy Cornell.
Here.
Kathy Hughes.
Here.
Jacqueline Bowman. Jacqueline, are you back? Ariel Hernandez.
Present.
And Dr. Joanne Spetz.
Present.
Great. We do have quorum. We will be continuing on. Item 7.0, discussion of possible action requirements in Senate Bill 1015 for NEWAC to study and recommend standards regarding how approved schools of nursing or nursing programs manage or coordinate clinical placements, and to report to the legislature. Presentation by Dr. Garrett Chan on health impacts receipt of grant funding from California Healthcare Foundation to study clinical placements.
Thank you so much, Janine. So great to see everyone. Glad to not be the chair this time around. As people may recall, Judy Cornell and I are on the subcommittee looking at the clinical placement issues, and part of the issue, clinical placements, is directed by the legislature, as Janine mentioned, in Senate Bill 1015 that got passed. And as being the former chair of NEWAC and really looking at this particular charge that was given to NEWAC, I realized that this is a big lift, right? And it's an unfunded mandate. So as a result, I knew that the California Healthcare Foundation was very interested in general around the health professions workforce preparation. And I also knew that the California Healthcare Foundation funded a project led by Dr. Diane Rittenhouse, who's a family physician with Mathematica, which is a policy think tank group. And Dr. Rittenhouse is just a phenomenal thinker and a great support to the health professions, including nursing. She is very inclusive. And Mathematica received a grant looking at clinical placements and clinical rotation availability for medical doctors, MDs programs, DO programs, nurse practitioner programs, and physician associate programs or PA programs in California. And I hope that, and I anticipate that the final report from Mathematica will be coming out within the next 2 months, clearly. And because I'm very good friends with Dr. Rittenhouse, and we have the same issues in nursing, I, as the CEO and president of Health Impact, which is the California Nursing Workforce and Policy Center, approached the California Healthcare Foundation to pitch this idea. And so we did receive a small grant for salary support to look at clinical placements. We will be including the issues that were raised in Senate Bill 1015 as part of that study. And I just wanted to let NEWAC know that this is happening, and there will be more information coming out over the coming year. And NEWAC, I recognize and fully respect NEWAC needing to do the work because it is mandated by the legislature. But hopefully there will be some synergies with our study along with NEWAC, and then whatever NEWAC would like to take up or not take up, that's totally up to NEWAC's discretion. We will be collecting some data using a very public and inclusive methodology. So I just wanted to share that with everyone because, again, as former chair, knowing that Senate Bill 1015 mandated us to do something, I wanted to make sure that things got done. So I think that's all that I had to share about this topic. We haven't even started, so but I did want to make this announcement during this meeting.
Thank you for that, Garrett. So SB 1015 was a bill that was put through last year, signed into law, and it does task the Nursing Education Workforce Advisory Committee to complete a study, and then it tasks our board to submit a report to the legislator on that. Completely in alignment with what Garrett had said, that he was part of the clinical placement subcommittee. We do appreciate that he just started kind of looking at that and seeing what needed to be done. I do need to do one point of clarification, and that is just to make sure that everybody knows that NEWAC, that we cannot rely on Garrett's health impact to write the report, draft the report, submit the report. You can utilize him and his organization as a subject matter expert, and you guys can use information that he has gathered and put that forward if NEWAC chooses to move in that direction in the future to our board, and our board then ultimately has the authority to accept it or not. But I just wanted to make sure that this was in the legislation. It did not direct the board to contract or utilize an outside source or anything for that. So NEWAC is not able to utilize health impacts report and then put that forward as theirs. So it can only be one of the data points that you may reference as you guys are drafting your reports. Just wanted to kind of come out in the front and just kind of let you guys know that although I'm positive that Garrett's team would do a great job. I've seen his reports. They always are stellar, but that is not what the legislator had requested. So we cannot just kind of lift and shift that and put that forward. So I just wanted to provide that direction. So
may I ask a question?
Absolutely, go for it.
I'm sorry, I'm just curious. I thought this legislation maybe came through in 23, 24, maybe chaptered in 2025. I'm curious if the NUAC has, I'm new to the committee, so I'm not sure. What's the action that we've taken so far on this legislative mandate? Has there been a subcommittee put together to begin some standards recommending? What's the action? Where are we at?
So where we're at is because NEWAC as an entire committee meets only twice a year, we have established subcommittees, and that's where Garrett was kind of referencing in his report out, is he was part of that subcommittee. So that is where they started working on toward this, and then towards the we have report outs to the full committee, and it was a larger undertaking than what they were able to put the focus on last year. So we're hoping that this year we make more leeway on that. It is something that is charged right now to a subcommittee of 2. It does not have to be that. What that subcommittee of 2 does, it allows for work to be done in between meetings. What we don't want to do is have our 3-hour NEWAC meeting be just kind of discussions around clinical placement only, especially when in our board's statutory requirement says 1 should be directed towards education and 1 should be directed towards workforce, right? So that would only be 1 meeting a year that we would be able to make any kind of movement forward. So the work is something that should be done in a subcommittee type format. Our board staff, as well as myself, are here to help in any way that we possibly can. But it's a large undertaking. So currently, Garrett, I know you're on the committee. I can't remember who your partner is right now on the committee. That's
Judy. It's Judy.
Thank you. And I know that Judy, you were kind of newer to NEWAC last year, if I remember right. So she was just kind of getting her sea legs steadied as well. So the other thing that's going to kind of put a little monkey wrench in this, I think Garrett terms out. And so we'll have to have new recruitment. We will have new people added. And so I think what we'll do probably at the next committee meeting is probably do a kind of realignment or reorganization of the various groups, because we do have several people coming off NEWAC this year, or potentially re-upping to the next term, completely up to them. And so nothing of substance has been produced yet, but the beginning kind of planning stages, lit reviews, all that kind of stuff, I'm sure has started. And it is a great undertaking, and it may even get to the point where there may be additional legislation that might need to be sought in order to bring this forward because of how large of an undertaking this is.
And then it is my understanding that there are some limitations on the number of participants in subcommittees. So that's also a challenge.
Yep. With the Department of Consumer Affairs, they have asked for boards and bureaus to play it safe at 2. So we do 2 across the board, just because those 2 people could also be members of other groups and other committees, which could inadvertently make a quorum of a committee that may not have been this committee that we were trying to avoid. We do see that happen. We see that risk occurring more within our board meeting and our board committees, but really just being mindful of that across the board so that we don't accidentally violate Bagley-Keene, because being a governmental agency, the mandate is to be transparent in every way possible, and that includes that work is done and reported out in a transparent manner. And so we have to publicly notice any committee that has a quorum. And so without having the subcommittees having more members, having the lower members allows them to meet as frequently as they want. They can meet 24/7 if they wanted to, any day, any night, without noticing, because you guys are gathering data and working towards that. So additionally, with the subcommittee, you guys can meet with any experts that you want. It's not limited. So you guys are able to meet with those experts. You're able to bring those in. You're able to have those conversations. It is not limited just to the Nursing Education Workforce Advisory Committee members here as your subject matter experts. You can reach out globally. There's not a limitation. So that opens it up too to have just a more robust input. So just kind of putting that out there, setting the stage. There's not been a specific plan that has been put forth yet. But I do think that a lot of these conversations and a lot of the conversation that you guys share in the last agenda item that I'm sure will be brought forward here will kind of start that and give this current subcommittee some direction on where to start kind of digging and looking and trying to get data and answers.
This is Ariel Hernandez. Thank you, EO Melby, for clarifying those points, because I had some questions about the objective for this agenda item. So just to make sure I'm understanding, I'm also new. My understanding is that this study on clinical placements funded by CHCF is a third-party analysis, and that members of subcommittees may review a number of third-party analyses, but that there's no requirement for this committee to approve every third-party study or analysis upon review. And so I represent CNA and sponsor of SB 1015. So if the objective was to approve this study, yeah, we would have concerns with that approach and about approving an analysis specifically by a third party without direction of the BRN.
Correct. So just to be clear, there is no ask to approve their study. As Garrett explained, he is doing a study separate from our board on clinical placements that was already part of his plan. And that I then jumped in to be very clear that NEWAC is not to accept his study as their study, that they can use it as data points, as some of their research, but they cannot take his study and I say him as because you're the CEO, Health Impacts the study as the report that will be submitted to our board for review and submission to the legislator. There is a clear line that has been drawn. He is able to, his company is able to pursue a clinical study in any manner that he chooses to, but that is separate from our board.
Thank you.
Separate from this Nursing Education Workforce Advisory Committee ask through SB 1015.
Thank you. Super helpful. Thanks.
Ariel, I really appreciate your comment because I did know that 1015 was a CNA sponsored bill. And I guess what I would just say is that it's my intention is to provide information for NEWAC to figure out what to do with the information, whether they take it or not, that's up to NEWAC. You know, I guess in the future, as being the chair of this committee for 4 years, you know, I think if there's going to be future legislation by CNA to direct an advisory committee that, you know, we're working with volunteers and volunteers have lives outside of NEWAC. And so if in order for us to get anything done, it really, we're reliant on volunteers to get stuff done. And again, everybody is so busy. So, you know, as things continue to progress, and I think that 1015 was absolutely the right piece of legislation to go through, thinking about what kind of resources would, you know, the board need to actually make these, do these studies in a timely fashion, because it is true that it was passed in the 23-24 legislative session. And just because people's lives are very busy, you know, it takes a lot to put something together like this. So, and yeah, I think that's my message.
I appreciate that. And yeah, thank you for bringing this study forward. I'm sure it will be very helpful. I think I'm just here to kind of provide the perspective as representing CNA, the legislative sponsor, and just to make sure that there's alignment with the intent of the legislature. But thank you.
Thank you.
Any other committee comments or questions?
If we have time, I would like to actually kind of encourage some of that discussion that was happening on the previous subcommittee report out on clinical placements, anything that you guys want to share out with the group so that each one of the members here are able to kind of take that information on. The reason that I asked that is in the makeup of this specific committee, it's incredibly diverse. And so as part of the Nursing Education Workforce Advisory Committee, we've got workforce representatives for both RNs and APRNs. We have education representatives, which are nursing program directors that are part of the CACN as well as COADN. We have education representatives from the colleges, community colleges, chancellor's offices, as well as with the CSUs and the state universities, chancellor's offices as well. So I'm sure there is a wealth of information that can be garnered from them. We have workforce representatives that represent the APRN workforce and represent the RN workforce. We have employer union representation. So you'll see CNA and SEIU and UNAC and such on here as well. And then we also have our data representatives with HCI, with our research vendor, and even with public members, right? So not everybody on this committee has the same understanding of what clinical impaction is and why we're here today and why this study is very important. So having you guys kind of crosstalk and share out the difficulties is hugely informative. So I know that I had to curb it on the last report out, and I felt bad of doing that, but I just couldn't allow for that to continue based on that agenda item. I really would love to start that conversation with here, listening to what Tanya Altman had to share and Wendy Hansbrough had to share. Those are really great information points. Alice, you coming in and asking the questions as a new member, just to get more understanding. Having Judy Corliss come in public comment, that was perfect. So if we can kind of replicate that here and start that conversation so that our committee can get a better understanding of the clinical impact, what that means, why this bill is, law, why this law was brought forth, and what these specific data points really can do in a state perspective and ultimately in a nationwide perspective. That would be of benefit. And so I really like to encourage you guys to start the conversation here. And I won't do a voluntold, but I will start the conversation if nobody else jumps in.
Hey, Lori, can we do that given that the discussion was supposed to be, the agenda item was specific to a presentation by Dr. Chan?
It was not specific. So it is on the requirements of Senate Bill 1015. So this agenda item was discussion of the Senate bill requirements and also Garrett doing a short presentation. So just to put it out there for the committee, I'll read this out so it's part of the meeting minutes. It's under section 2785.6 of our Business Professions Code, and it is H1. And it says the committee shall study and recommend standards regarding how approved schools of nursing or nursing programs manage and coordinate clinical placements. The study shall include at minimum all of the following topics: how approved school of nursing or nursing programs maintain clinical education standards, the participation of approved schools of nursing or nursing programs in consortiums with other approved schools of nursing and nursing programs to manage or coordinate clinical placements, the necessity and feasibility of a statewide consortium or regional consortiums under the regulatory oversight of the board to manage or coordinate clinical placements of approved schools of nursing or nursing programs, identifying and reporting violations of section 2786.4, that is that pay to play, ensuring fair and equitable access to clinical placements among approved schools of nursing and nursing programs, and identifying necessary information for the board to collect to ensure that approved schools of nursing and nursing programs comply with standards recommended by the committee. To start this off, there are in each state in our nation in the 4 additional territories, each one of us has our own Nurse Practice Act. Each one of the Nurse Practice Acts set their own education standards, their own scope of practice standards, their own licensing standards, and various ways that they approve nursing programs. Every nursing program in the nation is required to have a board approval in order to sit for NCLEX. So we do all have a type of board approval for our education process, but each one of the education approval processes are different from state to state. One of the states actually does all of the clinical placements for the schools. There is a state out there that each one of their schools report their total student populations, names, locations, all that kind of stuff. And the Board of Nursing makes the clinical placements for them. I can honestly speak for our board without even having to take it to a vote. I don't think that our board would ever want to do that. That is your guys' expertise. We don't want that, don't have the ability to do that. And so I'm not asking for us to take over clinical placements, right? But if that's where the data leads, that's where that is, then that data is important to share. There is a state in our nation that does that. There are also states that have a statewide consortium that is managed by the board, not ran by the board. So Nevada had a statewide consortium that was part of the board's oversight. The board implemented it. That was not something that the board could maintain, and now it is contracted out. That is something that our board has been very vocal on. In our California state audit response in 2020, that was one of our biggest responses. Our board felt that we needed a statewide clinical consortium. Not that we needed to manage it or run it, but that we would host it and have the data readily available for anybody to utilize. In that kind of feedback process, many of the people reached out and said they would want regional consortiums. I understand that throughout California, regional consortiums are pretty necessary. However, regional consortiums should all report back essentially to a statewide consortium. That's kind of the data there, so that you can have equal data points and be able to gather data on a consistent basis so that we can report out, right? That's where, there's a lot of times where HCI is a data collector for our state, and they do that. There was a bill that Senator Roth put forward that required some specific data points, that it would come from the healthcare facilities. They would report it to HCI, and then BRN would use that data. That didn't make it out of appropriations, but I can tell you I worked on that bill, had the support of our board, and it really looked like it was going in the right direction. So there are many, many governmental agencies as well as private agencies that are working towards this issue. There's a lot that kind of play into this. And sky is the limit right now for this committee to really take a look at it and see what is out there and what could benefit. If you're ever at any of our education licensing committee meetings, you could see where this really comes out in the forefront. any one of our nursing programs, when they want to grow enrollment, when they want to start a new campus or start a new program, this is really the sticking point that comes in there for discussion. This is where programs that are wanting to grow and expand or become a program state that the programs that are already here are not giving accurate information, or that the BRN is blocking. And then our current program directors show up in public comment saying, no, you guys are not telling the truth, that I am actually affected by this. I have proof. Here are my receipts. This is the issue that's going on. And I lost clinical placements because you guys were approved and started using that. There is no easy answer to this. And what our board has ultimately started asking of our clinical partners through our regulatory and statutory authority is to demonstrate the collaboration. That is truly what a consortium does. It provides a format for that, that transparency and collaboration. In addition to that, what the consortium hinges on is the members of the consortium. That really is, it's only good as the facilities that are part of that. If facilities in the region that are using that regional consortium are not all part of that consortium, then that consortium is not as robust as it could be. If facilities are making clinical placement outside of that consortium and giving it to another academic institution, then that's not being reported out through the consortium. And how can that collaboration take place, right? Our board has no jurisdiction over clinical facilities. The board's jurisdiction only exists within the academic setting that we approve. That is it. Absent any statutory ability for our board to require healthcare companies to utilize a consortium or to only do clinical placements in a consortium, that would not be something that we could enforce. Again, that's why this study is really important, so that those kind of details could, if validated, be something that could be reported out. And so that is something that I think should help you guys kind of start the conversation, take a look at that. Again, I'm going to do a shout out to Judy Corliss. She had a really good point in public comment about what occurred when we moved our direct patient care requirements down to that minimum. Did schools adjust down to that minimum, or did they choose to maintain a higher direct patient care requirement for their students because they can? And what did that effect have? I know that there was some federal legislation that came out requiring private for-profit, some of those institutions to only deliver the minimum requirements, and they could not deliver something in their curriculum that required more than the minimum. That's not something that has been brought forward here in California to that kind of standard yet. It doesn't mean it won't. So those are all things that can be looked at. The board sets minimums. Maybe it's a maximum. Maybe it's this is what it is. Maybe there's a statewide curriculum, right? Each curriculum is different. Each curriculum has a different focus. Each curriculum has different units and different units allotted. One of the examples that I commonly use, and I think I've already used it today, was one school might have a pediatric clinical rotation that's 2 units, much smaller hours than a next school that might have a clinical rotation that's built as 4 units. Different requirements, different impact on the community, just by the way that the curriculum is designed by each of our schools. And so this is a very large undertaking. Garrett was not wrong on that. And it definitely requires some really big time commitments to bring this forward to fruition.
Any other committee members would like to make a comment or ask Dr. Chan any further questions?
Well, I'd just like to mention that when AB 1577 came around, it's really about clinical placement and being able to document and provide to HK or CHI the, I guess, proof, if you will, that if a state college of any kind has requested a clinical placement, then the facility of which it was requested needs to be able to provide what they did. They at least met with them. And that if they did not allow for clinical placement, why they didn't allow for clinical placement. And I think that data is going to be really helpful in sort of figuring out where the gaps and holes are, along with the work that Garrett has done, and kind of pulling some of that data in. One of the things that seems challenging, two things that I think are particularly challenging around this topic. One is private schools. So there are a lot of private schools, a lot of private nursing programs that are not state funded in the sense of they're not required to report on AB 1577. So they don't have to say who they reached out to or whether or not the facility they reached out to got back to them, or if there's any gaps there. So that right there is going to show a gap. I think limiting the study to state colleges is probably a mistake because it's not going to give us a full range. The other piece is that there are now out-of-state colleges and programs that are seeking clinical placement for their students within our state. And I wonder, I don't know, but I wonder how many of our own state students lose a spot because that spot is given to an out of state. Now, the student might be a California student attending I don't want to say virtual, but essentially a predominantly virtual program. And then that all ties into faculty. So some facilities, oh, sure, we would love to have you place clinical here, but you need to have a faculty member on site. And not all programs are able to do that because of the issue with being able to sustain faculty for that purpose. So it's very in-depth and very rich.
There is, real quick, Judy, I'm going to jump in. I'm not sure if I'm going to make a joke here. Somebody saw me started to twitch. Let me do a little law realignment really quick and just set the stage. There is no out-of-state school that can have clinical students participating in clinicals in our state. That is not allowed by law. So if they have an out-of-state school that has not been board approved, please note that if you're offering clinical placements to them, that is not allowable. Please cease that immediately. If you guys are aware of that, please report it to our board, and we will also reach out and do a cease and desist as well. The only ability for students to touch patients and provide care in California is by them being able to provide nursing services through being enrolled in a board-approved nursing program for pre-licensure education. They have no other ability to do that. And if you guys are doing that at your facility, you are breaking the law. Please stop. So no, out-of-state schools should not, unless they have a California board approval, be having any student at any of our clinical facilities within the entire state. I know that there is legislation that has been put forward in the last few years requesting that, especially for larger for-profit organizations outside of us, and that has not made it through. So that as of today, that law still stands, that in order for a student to touch a patient, provide any kind of care to our California population, it must be done through a board-approved nursing program. With that said, we'll move to the next kind of redirect, as I can go off on a tangent for that. I'm so sorry. One of the other things that Judy, you brought forward there is that you said that a faculty member must be present when clinical hours being provided, and that is not accurate either. So maybe I misunderstood it, but faculty do not have to be present at a clinical site for clinical practice to occur. There's a common preceptor model that is utilized, and through verifying licensure, making sure that that licensure is active and not unencumbered, and that they've been at that facility for greater than a year, and that they have the competencies, they've been provided the orientation, they have communication set up with their faculty at the board approved program. A student can, as long as they've been competency validated at that school, be in a clinical environment without a faculty member present. They defer to the preceptor model, and a preceptor at that healthcare facility is the one that will be working directly with that student. That preceptor model can be utilized in any aspect of the program, from fundamentals to advanced med surg and anything in between. You do not have to complete all of your nursing coursework to make that happen. So that also helps to facilitate apprenticeship programs, not having to have faculty member there. That's a great thing. That's always something that is available to us in California. That also allows for, nursing programs to be in all areas of our state without having to have faculty present. They have to have faculty are the ones that are responsible for the grading of that student and granting and delivering that grade. But they do not have to be physically present for any of those clinical requirements to be done. So just to provide those kind of additional points of clarification there when looking at clinical placements. And we can utilize in California non-faculty to educate our students. They do not have to be hired by the program. They can be a non-faculty. That program can just make reports and documents available if we ever did kind of a review to ensure that those non-faculty people that are used to provide experiences meet the requirements.
Thank you for that clarification, Loretta. And let me just also clarify that I was not saying that it was a requirement. What I was saying is that there are places that a school would reach out to, and they say, if you do not provide a faculty member on site, we will not allow you to have a clinical placement in our organization. So I apologize for misrepresenting that.
No, and I could have misunderstood. And that is a common thing. One of the things, I meet with several stakeholders, and I think I came across a question that said to me, why are the union representatives involved in clinical placements? That doesn't necessarily make sense to them. And I said, because the union representatives represent the nurses that are paired up with the students and have a direct effect, right? And then even meeting with other organizations, just hearing the impact of providing that clinical experience on staffing that are already part of that clinical facility. It is a lift. It is a requirement by that facility and that staff within that facility over and above what their typical job is. And so that union representation is really clear. One of the other things to jump in real quick, I know, Judy, you brought up AB 1577. AB 1577 just requires a facility to have a conversation with a community college. It does not require them to supplant or to grant a clinical placement. HCI was tasked with that. If you go to their website, they punted it back over to us. We will be the ones that collect that data, and they will be the ones that use that data. Currently, that could change in the future. And right now, in May of this year, we released what's called a clinical facility approval or authorization portal, that this is kind of facilitating that kind of transfer of data. Some issues with that launch. It did not go smooth, and we have a lot of work to do. HCI is going to be utilizing that data that we're collecting there to be able to provide that information. And so we continue to work on that database and that ability to do it, but it really comes down to the clinical facilities inputting that data into that data bank. And so anything that you guys can do to help us encourage the use of that so that we can make that mandate of AB 1577 more readily available to HCI. We appreciate that, understanding again that the board has no jurisdiction over any of our clinical facilities, because we can't force them to do any of that, but we do ask them to participate in that. And so that is what I'm hearing commonly from our schools that are utilizing that data bank, is that they're stuck. They're stuck in the approval process because the facility is not signing in and approving them and moving them forward and providing their input. And so it's not making it to the NECs to get that clinical place approved. And that is key when dealing with clinical placement issues, because if you have a site you want to use and our NECs want to approve it, but the facilities are not saying, yes, you guys can use it, that becomes problematic in nature and really ties up that resource that you guys can have. So that's an issue. And then also one of the other comments, Judy, that you made around private colleges and universities, whether for-profit or not for profit, and the difference between kind of state-funded colleges and universities. Yes, AB 1577 did not address the private colleges and universities, but we oversee all. And there is no difference in the data collection that we do. And all clinical placements for all of our California nursing programs have to be approved by our board prior to use. We have the data. We know what programs are using what sites and what sites have approved them, et cetera, et cetera. So we have that. We do hope to have a data cleanup within the next year and be able to publish that data out. What we don't know is specific denied conversations, right? But what we will have is when the school enters the information into our data bank that says I talked to them, and a facility doesn't approve it, we will have that data that we will be able to report, where school tried to get 3 sites approved and 3 sites were not moved forward by the clinical facility. So we will have that data. The clinical facility is able to go in there and say why they didn't approve it. And so we'll have that data that can be reported out. But that, again, is just in the infancy stages. And we have a hope that it will be next year that we'll be able to start sharing some of that data, but I can't guarantee that. Again, it comes down to how well that data bank is updated and implemented, and whether or not we get the responsiveness with our clinical partners that we need to be able to get this data so that we can have more solid data that can be reported out.
Ariel Hernandez, just wanted to make a quick point about SB 1015 and the intent with the legislatures in passing that. EOMLB made a great point about how the BRN does have a lot of data, and that I think our committee would be well suited to analyze. And we look forward to analyzing that data and seeing where the issues are with clinical placements.
Has there been, I'm sorry, Cherie Fortin, California Community Colleges, has there been any sort of landscape analysis by Byrne to solicit sort of specific stories or feedback besides the clinical approval portal?
So we do. On our board website, we have all of our board meetings are posted with the board materials. You can go into our board materials and look at a progress report document that's turned into our education licensing committee, as well as our board, and that materials put forward. There are clinical and faculty issues that when shared by our program are reported out in a public manner there. they will show that they had decreased units, or they had to halt a admission, or they chose to, as a program, to voluntarily decrease their enrollment numbers because they didn't have the resources to support that. That stuff goes out to our board in those progress reports, specifically labeled clinical impact and faculty issues and stuff. So that is collected and reported out to our board. Again, it would take a data lift to be able to gather all of that kind of stuff. It's there. And I'll be completely transparent with this, it was on the California State Audit as well. We are holders of data in many, many ways. It doesn't mean that we utilize the data in the way that is that it could be utilized, right? And that is because our board is a licensing board. Enforcement, we're not a data driven board. I can't say data driven, but HCI is the one that collects that, right? And they have the statisticians, they have the research analysts, they have all of that to be able to utilize that data in a purposeful manner. That's also why we contract with UCSF to do our data collection, right? Because they are the experts, not us. And so we as a board have access to a lot of data. That data is not readily available in electronic forms to be able to bring that forward. That is why our board has strategically done a couple of items in the last few years. That is why we have our faculty approval process now in Breeze. Our faculty approval process now being in Breeze allows us to pull reports, allows us to get data, allows us to trend things year to year to year. Unfortunately, that data has a hiccup because in our last sunset bill, they said that our schools that have a nursing approval no longer have to gain BRN approval of their faculty. So now I only have a partial data number. I don't have data that says all of the faculty throughout the state because we no longer have that approval requirement. So although really great for our schools, not so great for our data collection at the BRN. So how do we manage that? What we did is we kind of went around and said, hey, you guys don't have to, but we highly recommend that you do that. And we are encouraging people to go outside of the school to get their faculty approval so that we have it on file so that we can still show faculty growth or depreciation over the years from year to year and say there's been a recession in this region of faculty, there's been an increase in this region of faculty, and we can now pull that data based on address of record. So we will be able to say we have this many approved faculty in this specialty area in this region. What we won't be able to affirmatively say is this is all of the faculty that are located in that region because it is not a full number anymore, because we do have accredited colleges and universities that do not approve their faculty through us moving forward since the last sunset bill. So again, we encourage that so that we have that data so that we can show it. It really would be helpful when having those conversations around faculty wages and such to show supply and demand. I can't provide that information anymore because I no longer have an accurate supply. I do have an accurate demand, but I no longer have an accurate supply because of the changes that happened in our last sunset bill. Additionally, when we look at the clinical placements, that was another thing, is really getting those resources. That's why we went to this data bank. We were collecting these fabulous forms that everybody loved, that is sarcasm, called an EDPP 18. And that form was filled out by the school, hand delivered to the clinical placement site. They signed it, and then the school came in and emailed it to us, and we approved it, sent it back to them and said, you're approved, go ahead and use it. You keep this document on file, and when we come and do a review, produce all that documentation to us so that we can show that you guys are in compliance. It was heavily burdened on the program to keep that information. And it was a very paper-heavy manual process. We updated that process to try to facilitate that in a manner that allows us to collect data that can be driven down to a regional level. That data is now within our clinical facility authorization or approval data bank, right? So now a school will go in there and enter their clinical placement information that they received. It sends an email directly to that healthcare facility that they're wanting to do clinical placements at, and that clinical coordinator or educator at that facility will say, yes, this information is accurate. We know that they're coming on our site and this is when it's at. Great, cool. It then moves on to our NECs and they review that to make sure that that clinical facility is able to meet the objectives that we have on file per the syllabus and our approved curriculum. And so then it could be approved and utilized. That approval process and that data bank is key to us being able to say, in this region, these are the facilities being used. What that data bank also allows us to do, and I have some samples where they've showed me the data already, is you might have a academic institution in region A using clinical facilities in region Z. And you're like, oh, I did not know that, but now it's there. Now it's there. Now we're able to pull those reports and now we'll be able to put those forward. Again, that has to happen after data cleanup. So we're continuing to work through that process. We are continuing to have data cleanup, but that again is a reason why we do clinical approvals, is we have the ability to gather the data that way. And we have the ability to require that information that says, we know your enrollment number, this is your need. We also know, based on what the facility is telling us, this is what they have to provide. So we can do a supply and demand once we get that data bank built and more robust. I know it's heavy lift right now. I know it's not serving in the manner that we want it to serve in because it is new and we're not having healthcare facilities kind of log in and approve like they should. But the intent of that is to have a really good, robust data. We will be able to, when that data bank is cleaned up and ready for publishing to our website, as per the California State Audit request, be able to say, and I'm just going to throw out names, LA City College is contracted with this many facilities, and these are the facilities that LA City College is using. What we'll also be able to do is the reverse of that. If LA City College says they're using Cedars-Sinai, we'll be able to pull Cedars-Sinai and see everybody that Cedars-Sinai has said, yes, we're using. It will also have dates and times and shifts. It will also have what they believe their capacity is, as well as what the school believes their need is. It will have that data. That data is going to be there, but it's only good as the data that's reported in, right? And so again, because there is no mandate at our healthcare facility side, we haven't been able to get that moved forward. So we're going to have a lot of data. For this report, I believe, and there's not a timeline on it, and I appreciate you guys want to be really, really on top of this, but for this report to be as robust as I believe it could be, it's going to be pending a lot of that data, because we, again, are holders of great sources of data. We don't have it readily available yet, and we're trying to get the data banks there for people to pull from. This information will be public. It will be out there, and you guys will be able to see where all of the schools are located on a map. You guys will be see where all those schools have clinical facilities located on a map. This is also what will be used by our board per the CSA direction to make really solid policy decisions based on what is the data that is here. So CNA, Ariel, you guys are absolutely correct in that we have a wealth of information. We haven't utilized that information in a manner that's appropriate, just because we haven't had the ability to do so yet. And that was really clearly identified in our CSA audit. So these are all steps towards making that happen. We do hope to have this information out to you guys within the next year, if at all possible. There is still some technological advances that we have to build in, and a huge data cleanup effort that has to come before we can put this data out, because what we don't want to do is report out inaccurate data. So as you guys are doing your kind of lit researches, you guys are making your plan, you guys are having these discussions that says, be sure to include this, take a look at this. I think this is important. This is all something that you guys are going to be in probably a planning stage for a while before we can even get that data available to you guys. So don't feel like you're behind the 8 ball yet. BRN's behind the 8 ball. We have a lot of data that we need to get out to you guys to be able to use. And we don't have the ability to do that yet, but we are working diligently towards being able to do that and provide that to you guys.
May I ask a question, Loretta?
Absolutely.
So I have two questions. This is Wendy. One question is, when we were doing the EDP 18s, as I know you're aware, the problem is that I would do one for my school, maybe let's say to UCSD, another school would do one for UCSD, somebody else would do UCSD. And UCSD was like, hey, look, I already filled out the form. It's the same data for all of you. So why am I having to do this again? So there was lots of confusion on the clinical sites as to what it was they were trying to fill out.
Yes.
So I know that part of the issue in trying to solve this is to get that clarified. My question is that you indicated that the board has no regulatory control over the clinical sites meeting this requirement. Is that true?
That is accurate. Yes.
So
we have.
I was under the incorrect assumption for all these years that, and it's partly comes from some comments I've heard from clinical sites that they must be approved as a training site by the board. And that apparently is not true. They have to do nothing.
They have to do nothing. You guys have to do it. That is where the lift comes from the academic institution, which is why our program directors are exhausted, right? I mean, you guys absolutely understand that. So as a program director, in order to utilize a clinical site for your facility, you guys have to go out and obtain the clinical facility. Then you guys have to submit that documentation to your assigned NEC to review and approve that facility. And we require a contract. In 1427, you guys have to have a written agreement that answers all of these specific sections within our law to be able to utilize that clinical facility. It is driven by you. It is driven by
have
the academic institution.
Yeah.
What was that?
Yeah, we have the MOU, but
Yeah.
part of that also has been getting the EDP 18 form completed.
The EDP 18 form meets our requirement in 1427 that you guys are saying you've met every single one of those requirements. You took all of that into consideration. We vet it, and then we approve it to be used. So we are no longer using the 18. Well, so I can't say we're no longer. We are aiming to no longer use the 18 and use the clinical facility authorization data bank, right? That's where we're going. We're trying to no longer use the 18. What we're hearing from our program directors is because the healthcare facilities are not logging into the data bank and approving it, they can't use that facility. So the authority that we have, which is not an authority I want to exercise, the authority that we have is telling the academic institution, you can't use that site because the facility hasn't agreed to it. That would be problematic for you guys, right? For the nursing programs, because we would say you can't use that site. So then again, the lift would come back on you guys to be able to go to your clinical facility and say, I need you to log into this. I need you to approve this so that I can meet my regulatory requirements and that BRN approve my site so that I could send students there. It's a very heavy lift for you guys. I don't want that to happen, right? What we want is this collaboration that says when you guys go in and have those conversations with your clinical facilities and say, hey, I want to have a clinical group here on Monday and Tuesday from 2 to 10. I'll place 6 students. Here's my faculty member. Here are my objectives. This is what our focus is for this semester. Do you guys have available? We can start in 3 weeks and we'll do it for 8 weeks and then we'll be out of your hair until our next semester. Great, cool. Everybody in alignment. Have them go in and sign that document saying, yes, all they have to do is say, yes, we approve. It's not a heavy lift for them. The reason that we had to implement that the healthcare facility had to get on board before it went to the NECs is during COVID, we had a lot of clinical facility fraud. So what we saw during COVID were academic institutions telling the BRN they're using these clinical placements for their students and they were not. Or they were using clinical facilities that did not exist. So we met with those schools, we had conversations with those schools, they halted using those schools, and greater than 500 clinical placements were removed because they were not true clinical placements. And so we had to bring the clinical partner into that so that it helped to decrease the data fraud and stuff that was happening. Us being a consumer protection agency, our role is to protect that student. And if that student goes to a program and a program says, I'm going to provide you direct patient clinical experience to meet the requirements for licensure, and that program fails to do so, and in doing so, submits data to the board that is not accurate or falsified, that is where we jump in. That is where we are at to kind of right this. That is our purpose. And we discovered that during COVID, that was happening at certain academic institutions, some at a very larger number than others. But we did have to have those conversations. And then another thing that occurred, again, more on a spotlight during COVID than before, is they were using clinical sites that could not meet the objectives. And so again, that is why our NECs have to review that and say, we know your curriculum, we know your syllabi, we know these are your clinical objectives. How are you going to meet that at a daycare setting? Right? Are you going to meet this healthcare pediatric direct patient care experience at a daycare setting? No, you're not. Okay, do you have other clinical placements in pediatrics that can meet that? Or do you need to adjust your objectives? Because if you're saying in your objectives that they're going to deliver medication to a pediatric patient and they're going to know how to do that, and you're not doing that in a clinical site, then why are you using that clinical site? But that is also where simulation comes in. So you guys can use simulation to simulate those events that work as an adjuvant to the direct patient care when those are not available, et cetera, et cetera. And that's why it becomes very, very complex. So
you refer to this approval portal.
Yes.
Where is that? I haven't used a new site for a while, but
okay.
Where would they go? Because I've been sitting here doing a search on the board and I can't find it.
We have it. It is emailed out to each one of our programs. It went out to each one of our program directors as well as their designees. We offered training, probably 3 or 4 training services back in April and May. Again, may have missed that, or you had a designee go in your place, and that's perfectly fine. Wendy, you as the program director does not need to be the one that manages it. You guys do that a lot already. So you might have a clinical placement coordinator. You may have had a faculty that utilize that, and they have a login, as well as our healthcare organizations that utilize that. They have a login as well, and they go in and utilize that. The initial question that you brought up, 100% agree with you when you said that each one of you guys were going to say Cedars-Sinai. They probably have 15 colleges and universities assigned to them, and all 15 of you guys were going in there saying, I've already filled out this form. That is accurate. What we also ran into on that initial push with the EDP 18 that the California State Auditors asked us to do is, depending on who you talk to at the healthcare organization, you got different information. Some would say, oh yeah, we can take them on Wednesday. And someone says, no, we're already contracted with another school on Wednesday. Some would say, I can take 800 students annually. And at the same facility, someone said, no, we can take 200 students annually. The data was not good data. So what we have as a fix for that is a clinical facility profile that is in the build. It is not out yet. And then we have a school profile, and that is in the build, again, not out yet. Once those profiles go out, it'll be one profile for every healthcare facility, and only one. They'll only have to fill it out once. They will not have to fill it out for every single school. We have 260 schools here in California. They will not have to fill it out 160 times. They fill it out once. The same with our schools. Our schools will fill out their profile once. And that will then kind of set the stage as to what is there, what is the supply, what is the demand, and we'll be able to move forward from there. So we hear you on that. That was glaring that data was inconsistent depending on where you went, who you talked to, how many times they'd filled out that form. It was duplicative in nature, and we worked really hard to address that. And that will be something fixed soon. And you guys will have an email soon that'll say, fill out your profile. And that will be that one and done and be used moving forward.
I think that's all that I have for this. I mean, we've had a very robust discussion. This is
Yeah.
a big topic, and we're gonna have to take some things offline. So I just want to thank the group for your thoughts. I'm glad that there will be minutes so I can capture everything, and that this is being recorded. So I'm gonna toss it back to you, Chair Graves, and then for opening up to public comment.
Yeah, again, it is discussion of possible action. No action is necessary. This could be treated as information only. So unless you guys have a specific request, public comment would be the next.
So prior to going to public comment, I'll ask once again if any of the committee members have any questions for Dr. Chan regarding this item. Hearing none, Mr. Moderator, would you please send this or open up the channel for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, I would like to make a comment. Please remember you have 2 minutes to make your comment. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Committee Chair Graves, there are no public requests for comments on the WebEx. We have no in-person representation in BRHQ. Would you like me to close this window?
Yes, please.
Thank you.
So since that was information only, we will move on to agenda item 8.0. It's also information only, presentation of the Accreditation Commission for Education and Nursing, Joint Accreditation Continuing Approval Visit Crosswalk that aims to minimize duplication, reduce the burden on nursing programs, and improve efficiency. And I believe that Lori's going to share her screen for part of this content to facilitate the discussion on the crosswalks. Lori?
I will, and I just want to start off by apologizing that the ASIN crosswalk was not published until early this morning. So you guys probably did not get a chance to completely review and go over that. But it is now on our website and it's under supplemental materials. It is draft. It is a very rough draft. So please let me preface that. I can tell you I've already made some updates just today where I'm like, oops, I missed that. And so this is just to get it out into the public so you guys understand the work that we're doing. This is not a final product. And in fact, once we get any feedback that you guys might have here, we will have continued work on it internally, as well as sending it to the nursing education consultants for review, the supervising nursing education consultants for a final sign off. And then back through the chief of licensing up to me before it's published on our website. So this is just in its infancy stages, but I want, again, as an effort to really be transparent, let you guys know, especially our program directors, our academic institutions, we hear you. And so we're going to do what we can to try to help and facilitate this, this requirement. So again, during the board's last sunset, we were tasked to complete our continuing approval visits with any accrediting agency, nursing accrediting agency that you guys might have approval from. That's ASIN, CCNE, and NLN CNEA. Those are the 3 recognized ones at this moment. So we started with ASIN. Once we get this kind of basic foundation done with ASIN, we'll move to CCNE, and then we'll move to NLN CNEA. So when we moved to the joint approval visits, we heard from our nursing programs. They were saying it's too much for them to do in every 5-year report for the BRN with our own specific standards, and they do in every 8-year or in every 10-year report for their accreditors. And then some of them do interim ones, and so some people were doing 4-year reports, 5-year reports, and then our 5-year report, and it was too much on their plate when they were trying to do the day-to-day managing of their program. And so we were tasked to align with the accreditors and to not require a separate report, that we would accept the report that you guys submit to your accreditors unless there was something in that report that didn't cover one of our regulatory or statutory requirements, and then you would have to submit something additional at that point. So we've been doing this now for a few years. We have amazing feedback. Most of the programs that we talked to said this was much easier, especially if it decreased the frequency to an 8-year visit with an interim report versus every 5 years. So that's heard, and something that obviously we will continue to support. But what we did notice is that we have, over 160 approved pre-licensure nursing programs in our state, each of them trying to write a report and give us a crosswalk as required in the statutory language of where we can find in their report our regulatory and statutory requirements. What we ran into with that is, even though, and this was one of the things that were kind of brought up with this part of the last couple agenda items, is even though 12 schools have the same accreditor, 12 schools are submitting a report different, and requiring a lot of work that the program director and whoever's turning it in says, oh, well, I didn't know that this met that requirement. So we took that feedback and we said, how can we streamline? And so this was our initial attempt to streamline. So in our beginning standards, we put all of our regulations and all of our statutes that go into the review and approval of our schools in this initial part of the document, and then any kind of BRN evidence that we look at that is absent, whether or not you're accredited or not. These are what we look at when we do our approval visits on non-accredited programs, as well as any accreditor that we do. So our first 2 columns on this document, and I will start screen sharing at this point. Sorry, let me pull that up there. I know you guys said I would, and then I just started talking. That's so true to me. I apologize for that. So with this, I'm going to share my content here. So the first 2 pages, and for those of you guys that have difficulty seeing it, a lot of times you have a pop-out button. You have the ability to kind of increase or decrease the size of your presentation on the screen, but I will do my part here as well and make it bigger. So this column here on the left side is all of the rules and regulations that we hold you to as the board. This is all of the evidence, again, including but not limited to, that we look at the board when we do your review. This is where we have looked at it and said, this might align with an ASIN requirement. And so we went through each one and just took a look at it and said, well, this is California specific. California specific, that's where we align as our approval, where accreditors are a national focus. And so understanding the difference between approval and accreditation is key. Approving body is us. It is required in our state that all of our nursing programs be approved, and that based on that approval, your students that graduate are able to be licensed and sit for the NCLEX. So it has a dual purpose there with that approval that is beneficial to your students, as well as the consumer protection that we provide also. Different than what our accreditors do. Our accreditors have a national focus. They do take a look at some of their requirements that you align with your state first and then move beyond that. But there is 2 separate focuses. So this one here, that it's not covering less than 2 years. It's conducted in affiliation with one or more hospitals and is an institution of higher education. That's a California specific, so you're not going to have an alignment. We need to look at your 05 and your 11. We need to look at those forms. So that's why it says NA. And you'll see different things like that go through. Again, our minimum requirement is 500 hours with 30 hours in each, a minimum and 30 hours in each. Again, that's not a national requirement, so they're not going to have that information for us. We'll let you guys know what we need for that. So again, that's why that's an NA. So these ones that say NA, those are California specific requirements that will not align with your accreditor. So we will need some additional documentation from you in order to vet that. However, when you're looking at here that there's a written statement of philosophy and objectives, that's greater than California. That's a accepted standard within your national organizations as well as here. So this is where we're showing this is our regulation, but this could also be criterion 1.1 of ASIN. And so we will look at the report when you're addressing 1.1, take that information and see that it clears 1424A to ensure that you're in compliance. So coming from our perspective, being one single board working with only 3 national nursing accrediting agencies, we figured that if we do this crosswalk, that we could help the 160-ish approved nursing programs to just have a general starting point. So we will go through all of this. I'm not going to go through each one, but I want to let you know that we've taken that information on how this may align in these ASIN requirements. And this should help you guys in preparing your ASIN report, as well as your BRN, as well as answering the BRN requirements, so that you guys don't have to do anything that is duplicative, that it helps you to streamline that and that we can get that from your ASIN report. So we did this first part is just kind of demonstrating, just kind of allowing you guys when you're getting ready to do your report of where you can kind of add additional information in to make sure that you're addressing your ASIN requirement, but also addressing our regulatory and statutory requirements at the same time, as to not have to add additional addendums, add additional forms or documentation unless it is specifically separate. Now I'm going to scroll down quickly so you guys can get down to what we are putting together as a working document. Again, not a final form. I've already altered it on my end, on my desktop, on just things that I caught after it went to publishing. Again, good thing it's in a draft form. And knowing that this has not gone to your NECs for approval yet, as you guys are aware, in our last sunset, it was that the EO has to do the uniform methods. And then so I'm starting it and we're moving it across, but I'm not going to take full credit for this. Our supervising nursing education consultants and our chief of licensing really did the huge lift, and I'm only doing the editing of it. So it was really reliant heavily on their input. So this here is the beginning at page 31 right here, the beginning of our consultant's approval report. This is a document that our NECs use when we go out to the schools and we say, hey, here is the BRN statute or regulation. What is the evidence? Do you guys, are you in compliance? Are you non-compliant? Are you needing any kind of recommendations from us on how to ensure that you maintain compliance? So right here, consistent with what was on top, 2786, you're not going to be able to provide a crosswalk to that because it's not included in your accreditation report. We need you to defer to the BRN requirements. And so that will obviously be as an addendum to your report that goes to ASIN. Does it mean that these forms cannot be turned into ASIN? Absolutely not. A lot of times ASIN has let us know that they like our forms, that it's very clear and concise, and that they use that when they're doing the accreditation review. So we've gone through and said when to defer to BRN requirements, but then these are kind of how we drafted right here, where we want to, as required by statute, it says you guys must provide a crosswalk. So 1424A, very basic requirement, says there shall be a written statement of philosophy and objectives that serves as a basis for curriculum structure. Such statement shall take into consideration the individual differences of students, including their cultural and ethnic backgrounds, learning styles, goals, and support systems. It shall also take into consideration the concept of nursing and, I can't see behind the draft, sorry, of nursing activities, the environment, the health illness continuum, and relevant knowledge from related disciplines. We know per the form above that this is answered in the ASIN report. So what we need you guys to do is say, is this included in the narrative? Yes or no? Is this included in the appendices? Yes or no? If it is included, what is the page number that it's on, or link me to that specific area? And if it is not included, insert any information or links where it could be found right here. And that is the crosswalk that you guys will develop when you're writing a report. Again, it's going to be consistent from program to program. Whether or not it's ASIN or CCNE, this document will stay the same. You guys will just add in the link to that, so that won't change. The above document will change on whether or not this is ASIN or CCNE or NLN CNEA. This right-hand side will have the accreditor's information that aligns with our BRN regulations and stuff on this on the left. So this is where we're heading. We're not there yet. Our goal is to streamline this as much as possible, to not require additional documents. Even though we accepted your guys' report that went to the accreditors, what we found is we still required a lot of information coming over from you guys in addition to your report. And that was not the intent of that legislative ask, and that's not really where BRN wants to live either. We want this to be a streamlined process for you guys. We want this to be easy for you guys to complete. And we want you to be able to feel confident in the documentation that you put forward, that you're going to meet your accreditor's requirement as well as BRN requirements. Because when we go to those site visits, your accreditors always ask us if there was any areas that you guys did not meet the BRN requirements. And that is taken into consideration on their review. And so we want to make sure that you guys are as prepared for each one of those reviews as you possibly can be, knowing that you guys are in alignment with all of BRN's regulatory and statutory authority, so that you can then, and we can, confirm to your accrediting agency that there's nothing that's outstanding on our end that could affect your accreditation standing. We want you guys to maintain that accreditation, and we want to not be a barrier to it. But we also know that your accreditors rely on you guys being in compliance with our state regulations and requirements first. And so that is why we are putting this tool together. It's out, it's public. Any feedback that you guys want to submit, please do so. You can send that to Macaulay Fuserans. You can send it to your NEC. You can send it to me. We will collaborate and get that together. Once we get to a more finalized document, I will work with our Chief of Licensing, Macaulay, to share it out with our NEC so that they can get a final look, and that any input that they have too is taken into consideration, because they're the ones doing the visits with the accreditors between all of the nursing programs, and you guys are seeing it from the programmatic level. So we want to get everybody's feedback. We've heard a lot of feedback already, which is why we created this. We are listening to you guys. You guys are telling us that the intent was to make it as streamlined as possible, and you guys have identified areas where some streamlining can still occur. So we wanted to capture that here and provide a single document, a single location. When this is complete, it will go on our website. And it will be available on our website for you guys to use moving forward. But we're starting with ASIN. We'll move to CCNE next, and then we'll end with NLN CNEA. Any questions, comments? I know we have 10 minutes left, so I want to take time to allow you guys to have any questions or comments. and go out to public comment before we wrap up our meeting. Okay, does not look like there's any questions or comments coming from the group. It's been a long day already. So at this point, it is information only. Janine, you can take us out to public comment.
Mark, would you please send this out to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Committee Chair Graves, there are no public requests for comments on the WebEx. We have no in-person representation in BRNHQ. Would you like me to close this window?
Yes, please and thank you.
Thank you.
That takes us to agenda item 9.0. Just wanted to put on your calendars, July 29th is the next NEWAC meeting. And I think this is our final meeting. Dr. Chan and myself, I would like to really thank him for his 4 years of superb guidance in the NEWAC committee and making sure that the voice of nursing is strong. I would like to thank, besides Dr. Chan, Macaulay, and Reza for their support, as well as the honor of working all these years since 2009 when I was appointed to the board with the deans and directors. You guys are doing the strong work, and you're raising the nurses that are going to take care of us. So thank you for doing a good job with that. You really made California proud. When I go speak at national conventions and this and that, it's always the beacon is how California nurses make us the best in the country. And we have you to thank for that. I'm very grateful for my nursing education at Fresno State, and I appreciate all of the work that you continue to do. So Dr. Sajay De Guzman is vice chair, and he will work with Macaulay and her team to do an agenda for the July committee. But I want to thank you for the honor of not only my board service, but service on this committee. So are there any further public comments before we adjourn, or committee member comments?
I do have one comment here really quick. We did have a public member that termed out. We did a advertisement for that. We received so many applications for that public member position, but they were nurses. And so they were. It was not a good response, unfortunately. So we will be recruiting for the nursing specific vacancies that are coming up. So, we will be recruiting for the position that Garrett covered with Health Impact. We're going to be recruiting for the position that Janine, you covered as well. So those recruitments will go out. I really ask that those that applied for the public member position, please reapply. The last recruitment, unfortunately, people did not read that it was for our public member, and was not RN based. And so the applications that we did receive, the majority of them came forward, and because they didn't meet the requirement for public member, we were not able to consider them. So we did receive your application. There was a great response. It was unfortunately misdirected. So we will be recruiting for the members that are terming out this year. There will be a new recruitment that goes out. Please, please, please don't think we denied you because you didn't meet a specific, or that we didn't want you on NEWAC. It's that you guys applied for the public member and not the nursing specific members. So we will be doing additional recruitment. Please go ahead and do that. And I just want to take a moment and thank Garrett specifically. He jumped in from our APRN committee as soon as that was sunset. So he had already served our board for many, many years and was willing to jump over and steer this ship as NEWAC was reformed, rechaptered, new appointments made. He brought his expertise coming in from APRN and brought it over to NEWAC and really helped to lead this. And I hope that as he terms off of being a chair of one of our advisory committees, which hasn't happened in a gazillion years, it's probably 10 years you've been a chair of one of our advisory committees, that you're able to get some needed rest, but that you will still stay as an active participant with our board and everything that we do to move California forward. So thank you, Garrett.
Thank you so much. Thank you, Lori, for your great leadership. Thank you, Janine. Thank you to the entire committee. This has been a really honor to work with all of you who have great contributions. And the future is bright. Let's continue to make changes.
All right. Thank
Hear,
you.
hear.
At that happy note, we will conclude our meeting. And I think if there's no further comment, we will close. All
Thank
right.
you. We are adjourned at 1:57. Enjoy your day, guys.
Bye-bye.
Bye.
Thanks, everyone.
Thank you, everyone.
Good job, Janine.
Thank you.